A young patient came to ER with abdominal pain that started near the umbilicus and then shifted to the right lower abdomen. Sounds familiar? Now let's break this classic case of acute appendicitis step by step, exactly how it is expected by the examiner and the ward round. Hello everyone, this is Dr. Asma and welcome back to the channel. Here we will simplify clinical cases for medical students. Today we will present a perfect case of acute appendicitis from history to diagnosis, exactly how the examiners expect. Starting with the history. Patient's profile. My patient Ali, 22-year-old student, resident of Charsadda, presented to the emergency department on 22nd of June 2025 at 8 p.m. with the chief complaints of lower abdominal pain, nausea and fever since one day. History of presenting illness includes my patient was in his usual state of health one day ago when he started suffering from abdominal pain that started around the umbilicus and then shifted to the right iliac fossa after 6 to 8 hours. It was sudden in onset, colicky in character, not radiating, associated with nausea and fever that exacerbated while sitting, walking and coughing, and relieved with lying down, and was severe with a score of 8 by 10. Nausea started along with abdominal pain and has been increasing till then, and it is associated with anorexia, but no vomiting was present. Fever was low grade, documented to be 99 degrees Fahrenheit, started with abdominal pain, was continuous in nature and did not lower to the basal temperature. It was not associated with rigors, chills or sweating. Upon systemic inquiry, patient did not have any bowel or bladder complaints and no other symptoms were present. His past history, including past medical, past surgical and drug history, were insignificant. There was no history of any allergies and he did not have any blood transfusions till date. His family history was negative for diabetes, hypertension, asthma, ischemic heart disease, CVA and similar episodes like the above mentioned case. My patient has anorexia, normal bowel and bladder habits, normal sleep of up to 8 hours. He has no history of drugs, alcohol, cigarette, etc. use and he drinks filtered water. My patient belongs to a family of 4 with 1 bread earner. He lives in cemented and well ventilated house with 2 bedrooms. There are no pets in the house, hence is socio-economically stable. On general physical examination, my patient is ill-looking and prefers to lie still and lying in bed, conscious, alert with no obvious signs of distress. His temperature was 98 degrees Fahrenheit, pulse was 98 beats per minute, blood pressure was 120 by 80 millimeters of mercury and respiratory rate was 18 beats per minute. There is no pallor, icterus, cyanosis, clubbing or lymphadenopathy present at the time of examination. On per abdominal examination, upon inspection, abdomen moves less on the right side with respiration. On palpation, there was localized tenderness in the right iliac fossa, maximum tenderness at the McBurney's point. Guarding was present and rebound tenderness was positive. Some special signs are to be seen in the case of acute appendicitis, including Roswing signs that was positive in this case, SOS sign that was positive and obturator sign that was negative for this particular patient. On percussion, there was no shifting dullness and auscultation, bowel sounds were slightly decreased. Other systemic examination, CVS, respiratory, CNS examinations were unremarkable. Our provisional diagnosis is acute appendicitis and differential diagnosis may include the following: mesenteric lymphadenitis, acute gastroenteritis, Meckel's diverticulitis, right ureteric colic, and if this patient would have been a female, then we would have considered ectopic pregnancy and ovarian torsion. Investigations that can be done for supporting our diagnosis includes the laboratory investigations, complete blood count that has increased leukocyte count with neutrophilia and CRP is raised. As imaging is concerned, ultrasound abdomen can be done and it may state non-compressible blind ending tubular structure with diameter of greater than 6 millimeters. And if CT scan abdomen is indicated, it is confirmatory for the diagnosis of acute appendicitis. Now coming towards the management. Initially, we make the patient nil per oral and then we give the IV fluids, we give a proper analgesia and IV antibiotics. The definitive treatment for acute appendicitis is appendectomy, that is either open or laparoscopic. Complications, if left untreated, may include appendicular perforation, appendicular abscess, peritonitis, and sepsis. If we summarize the whole case in one line, it may state as: a young patient with migratory right iliac fossa pain, fever, localized tenderness, and raised inflammatory markers is suggestive of acute appendicitis. If this case presentation helped you, please like the video, subscribe, and share it with your batchmates. Comment below if you want OSCE stations, short cases, MCQs, or surgical viva questions on acute appendicitis. This is Dr. Asma signing off. Keep learning and keep saving lives. Thank you.